I'm delighted to be here. I'm excited about being here for lots of different reasons. I think change is happening. I've been in the profession long enough to know that we've been talking about change forever, and I've been waiting forever, and it's here. So for the young people in the group, this isn't something that we're talking about in the future. The fact that you're not doing it today sort of puts you behind. So I'm here to encourage you to hurry up, essentially is the bottom line of what I have to say today. And I say hurry up not for our sake, because hurrying up is never comfortable, change is never comfortable, but the environment around us is ready for the opportunity that pharmacy's been talking about for 60 years. So if you don't take advantage of this opportunity today, pharmacy has a real risk of losing it. And I don't say that lightly, but I'm in an environment where change is happening very quickly, and I know that to be a fact. I'm going to talk to you about what's going on in the United States, and many people, I travel all over the world, many people want to believe that what is going on in the United States isn't going to affect you, or that you are different than the United States, and obviously that's true. However, I believe that we are all going toward the same healthcare system, and we are all going to end up in exactly the same place. The world is getting smaller and smaller. The ideas are being transmitted faster and faster. So what works in the United States is going to work in Scotland and in England and in Wales and in Northern Ireland. People are sick and they have the same number of kidneys and the same medical conditions and the same physical parameters. So a patient care service that works in the United States is going to work here, I can guarantee it. The other reason I know that it's applicable here is because we have the same goals. Your national health system and my health system have to accomplish the same goals in the next 5 years in order for our systems to be maintained. I just want to tell you a couple facts about the US system to convince you that we're functioning in the same arena. Over half of the dollars spent on healthcare in the United States are spent by our government. I know that comes as a surprise many times, but the services that I hire pharmacists for today are being paid for by the federal and state governments. It's not private enterprise. So for those of you who already think that you don't have to do this because that just applies in the private business world of the US, that's wrong. We are working inside the federal and state governments to deliver this service, and we're being paid for it. You'll see a little emblem on the bottom there, Medication Management Systems. That's my company, and I'm not selling anything today. But for the young people in the audience, I want you to know that we're hiring pharmacists today to deliver pharmaceutical care full-time, stop. Not tomorrow, not if things work out. We're hiring them today. Pharmacists that either work for my company or work on the software my company provides is providing this service to thousands of patients across the entire United States today, okay? So this isn't a futuristic possibility. This is happening today. This is the new standard of care that you will be held to. I can promise that, and I can promise it's going to be happening way sooner than later. The statistics that were talked about just a moment ago by Mark, we all know those statistics, but we haven't internalized them as our problem. They are our problem. We are the professional who's supposed to be protecting patients from drug therapy problems, and we're not. So we have to start internalizing these numbers. You know, Mark, perhaps I should have mentioned at the outset, I tend to be a bit direct, for those who haven't heard me before. And I want to apologize in advance if I offend anyone. I should have done that earlier, but that doesn't come naturally to me. I'm sorry about that. But I'm direct for lots of reasons. First of all, I'm an American, so sorry about that. I'm married to an Englishman, so I find out constantly how we're different. But it's lasted 32 years, so I think it's okay that we talk to each other this way. But I'm direct because we have to figure this out quickly. Pharmacy's been talking about this way too long and doing nothing. If you really want to reclaim your professional territory, you quit talking about it and you start doing it. Okay, it's that simple. The rest of the world isn't listening to what we're saying because they listen to things based on the actions people take, not on the words they use. So that's why I'm as direct as I am. So we have common goals. And I happen to think, and my federal government now happens to believe, that our services are what's going to help get these goals achieved. Drug therapies represent over 85% of the treatment modalities in both of our countries. If we don't have control of medications, we don't have control of patients. So we're all headed in the same direction. As I mentioned, because it's such a common treatment modality, it impacts everything. And now in the United States, the value proposition, and I'm going to talk a lot about value because the national health system has to save money. Money is translated into value in a capitalistic system, which we both have. If you're not being paid for the service, what you're doing is not valuable. You don't have to like that, and you're going to hear a lot of rules today you aren't going to like. That doesn't change the reality of it. Pharmacists have been sitting in a very safe corner. We haven't been noticed by many people because what we do for patients doesn't have value based on the dollar that the system pays us for. So that has to change. The only way that's going to change is we bring value to the patient care equation. So I'm going to talk a lot about value. Value is measured very precisely, quantitatively, and we now know what the value of this service is. This service has had more research applied to it than medical services, dental services, and nursing care services put together. We can put an argument forward that anyone is convinced of. So those are no longer the problems. The problems is our communication and what we do on a daily basis. But we impact every single segment of the healthcare system every single day. So the way we've won our situation in the United States is by bringing drug therapy to the front of patient care instead of letting it sit at the back of patient care. Drug therapy isn't something that happens and hopefully is done well and hopefully doesn't cause problems for the couple that you saw. And drug therapy isn't something you wait for problems to develop before you look for problems to prevent. That's the way we've managed medications in both of our countries. That's not the way to save money with drug therapy. You have to put it out front, and you have to really get it out front, because until you get the medications right, a patient is not going to get any better than they are today. And trust me, our patients aren't well. In the United States, we have 3 criteria we have to meet in diabetic patients. It has to do with a hypercholesterolemia, it has to do with blood pressure, and it has to do with glucose. Less than 20% of our patients are within therapeutic range on those 3 criteria. That means 8 out of 10 patients are not being managed well with the most expensive healthcare system in the world. That's unsustainable. But the fact that that situation exists is our fault. We're not managing a patient's medications, and that's our fault. So we have to put medications out front because the value of what we contribute can't be realized unless we are playing a real role in healthcare. That means that we move over to medicine and we quit with our pharmacy focus and our pharmacy preoccupation because the answers aren't in pharmacy. The answers are in the professions of medicine, nursing. So we have to look to them for what we need to do to be successful, and the answers are very clear. The answers are very simple. The answers have been around for a long time. We've just never asked the question, what do we have to do to be a successful patient care provider in the healthcare system. And there are rules, but there are only 5 of them, and they're very simple, and we're going to talk about them in a moment. I included some background, but these statistics, Mark had way better statistics because they're British statistics, but the numbers are all the same. The drug therapy problems out there are astronomical. 70% of our patients, all of our patients, have a drug therapy problem that's keeping them from getting to goal. Okay? 99% of the patients we see every day have a drug therapy problem that's keeping them from getting to goal, and 75% of our patients have more than 5 drug therapy problems that are keeping them from reaching their therapeutic goals. And they will not reach their therapeutic goals until those problems are solved. And right now, in both our systems, no one is looking for and solving those drug therapy problems. So we can't save real money until we do in our healthcare systems. This is a small group of data from a sample of about 780 of our patients. We've got so much data. We've now documented the care of almost 1 million patients with this service provided by pharmacists in the United States with our system. The average number of drug therapy problems is 6 in the population that we're providing this service to. And as I said, almost 3/4 have more than 5 drug therapy problems. So these patients will never get to goal until we manage and intervene at the level we're talking about. Now, a lot of times we talk about adverse drug reactions, we talk about non-compliance. Those really are the least of our problems. So the problems, the very problems pharmacy's been focused on really aren't the problems at all. When you look at a patient's drug therapy comprehensively and systematically with the rational decision-making process that pharmaceutical care brings to the equation, you end up with these statistics. The first thing you notice is that we've been taught that we are both in over-medicated societies. That's actually not true at all. We both exist in inappropriately medicated societies. So almost 1/3 of our patients required more drug therapy. Okay? Now that is not to say that we didn't take drug therapy away as well. But our patients are not on the appropriate preventive drug therapies. They're not on the appropriate synergistic adjuvant drug therapies. So if you just take that drug category, you know that pharmaceutical care is good for business, right? So there's lots of advantages to pharmaceutical care. We add drug therapy to patients, but it's appropriate. The other thing that you notice is the second largest category is probably a surprise to you. It certainly was to me, and that is that patients are on too low of doses of drugs to be effective, which I think is the most unfortunate category in this entire list. Physicians put patients on the right drug for the indication, but because we're a litigious society, especially in the United States, but here as well, physicians are taught to start low and go slow. Well, they start so low and go so slow that 25% of our patients never reach therapeutic range, and they can't, even if they're 100% compliant with the drug regimen they've been given, they cannot reach therapeutic goal. That's expensive. These people keep coming back, they keep being symptomatic, they go into hospitals, and yet they're on the right drug. So in 25% of the drug problems we find, we increase doses of drugs. There you go. I just increased sales again. You're welcome, okay? You'll notice a couple other things. There aren't a lot of adverse drug reactions out there for us looking for them all the time. They don't exist, but let me tell you why they don't exist. The other thing is non-compliance is not that big of a problem. which at this point you think I'm crazy because the literature says non-compliance rates are upwards of 75 to 80% in older patients who are on complex regimens. The reason that our patients have a non-compliance level of 14% is that pharmaceutical care requires that you look for these problems and solve them in a chronological order. There's no reason to look for an adverse drug reaction if the drug isn't necessary and indicated to begin with. And for all of you who are trying to increase compliance when patients are on inappropriate, ineffective, and unsafe drug, you're the problem, not the solution. Okay, so you pharmacy students and early graduates, don't try and increase compliance. It's unethical. I'd go so far as to say it's immoral, because unless you do a comprehensive evaluation of that patient's drug therapy and you know that the drug therapy is appropriate, effective, and safe, you have no right to intervene and make that patient compliant on that drug therapy. Patients make decisions for very good reasons. They're way smarter than we are about what works, what doesn't work, what is causing problems, and what isn't causing problems. Because 75% of the time, the problems are real, and it's because of inappropriate, ineffective, or unsafe drug therapy that they're not taking the medications. And when you fix those problems, you find out that non-compliance is about 9 to 15%, usually due to cost, or to the reason that was explained in the film, which is nobody told me what to do. I didn't get it. I was worried. I was newly diagnosed diabetic. I realized my whole life is going to change. And then they tried to tell me how to use insulin, and I didn't get it. So of course I'm non-compliant because no one bothered to find out whether I understood what was going on or not. And they said, if you have any problems, just come back. That's not a service. That's not how we deliver services that we're accountable to deliver. So with that problem profile in mind then, we've got a lot of work to do. And there's another reason, because both of our healthcare systems are looking at money like they've never looked at money before. I think they were kidding until now, if you know what I mean. Now, the money is getting to be funny money. It's costing so much money to deliver healthcare services that we can't sustain the systems that both of us have created. In the United States, in 3 years, 4 years' time, medications will cost the system half of what it takes to deliver care. Now, when I was in graduate school, it was 9%. Dave, is that right? Dave, where are you? Was it 9, 10%? That's right. Then it became 13%. Then it became 15%. Then it became 18%. And we're jumping from 20 to 50% in about 4 years because of the specialty drugs. Because we're getting, for some good reasons, we're getting a handle on medical conditions that were never treatable before. We're treating hepatitis C. I mean, we're curing it. We're not just palliatively treating it. We're curing hepatitis C. We're actually impacting the prognosis of rheumatoid arthritis. We're doing things we've never done before, but we're doing them with very expensive drugs. Now, you have a much better way of controlling those expenses than we do, but they're going to be here very soon. So if we're not managing those medications in a cost-effective manner, again, the problem's going to lie with us. You know, the new hepatitis C drug therapy in the United States costs $50,000 a treatment regimen. Look how many patients you can take care of with $50,000. Given the figures I saw earlier, a lot of patients. So one patient that has been misdiagnosed, perhaps correctly diagnosed, but the treatment was not appropriately administered because you've got to take the drug for this to cure it. Just one patient. We have just prevented that many patients from receiving care because the drug was mismanaged. We are now at a level where someone's going to notice that we're not doing our jobs, okay? So we've got to act quickly to have an impact on these statistics. Now, one of the things that pharmacy has done is to create a whole lot of mess out there. And oh dear, something else I should have said earlier. I critique the profession in order to change it, okay? I don't critique it because I don't like it or because I'm a bad person. I might be that, but I critique it so that I can fix it. One of the things pharmacists are famous for doing is working off of what I wish was existing instead of what actually is existing. I work in the real world. I left the university 5 years ago now. And I work in a real world business environment where we have to deliver care, we have to deliver service, and we have to deliver value in order for me to sell the service that I'm delivering. So we have to produce. We have to produce real results. Well, we've created a very uncomfortable picture out there because we've created a whole lot of programs that are ends in and of themselves. They start and they finish. We also do projects. Have you noticed that in pharmacy? We do projects in pharmacy. Well, there's no room for projects in the practice in patient care because patient care is a full-time job. It's not a hobby. It's not something we do when we have time, if we're interested, if we feel comfortable, and if all the stars are lined up just perfectly today. That's a hobby. That's not patient care. And until we recognize the difference between the two, we'll never open the door into patient care services. We have to get serious about the patient care that we deliver. Well, this has created a very fragmented picture out there that we've got to fix very quickly. And the nice thing is that when you are able to deliver a comprehensive service where the patient is at the center, you can tie all those fragmented programs together overnight, literally, which is what I do all the time. You tie them together because those programs pretty much exist in pharmacy without the patient, even knowing the services are there. They're a step away from anything real in terms of value because I can't measure what actually happens to the patient with those services. Once you start taking care of the patient, you can bring in utilization review and adherence programs, and you can bring in performance measures. In the States, we call those star ratings, but they're just performance measures, which are going to come here very soon and be very real. But it's a way for us to get our act together. We can now provide a service that unites the needs of a patient instead of fragmenting them and creating all of these programs, which are expensive to administer because they are isolated and they have a beginning and a middle and an end all to themselves. These are the trend management opportunities. I learned this word from Dave McLean, who I asked for his help. He's here with me. He's the CEO of our company. We are doing business with a company here in Amersham, so we were here for a few days. And he's the business guy, I'm the clinical guy, so if you want to know anything about what's happening in the United States for real, you can ask Dave. But I can tell you about practice, so I'm not a business person. You probably already knew that. But I learned from him that all of these opportunities lead directly to pharmaceutical care. Now you can say those words and everything really sound American, and that's true, but they're coming to your house. Simon Stevens, who's the new head of the National Health System, I guess he started last month. I just read an article about him in the paper here yesterday. He's worked for 7 years at United Healthcare in Minneapolis, Minnesota. We work with United Healthcare now. My company works with United Healthcare, so I know exactly where Simon Stevens' head is at. And every one of these things, I'd write them down if I were you, because Stevens is going to bring every one of these to your house in the next few weeks, okay? He has every intention of bringing what he learned in Minneapolis, Minnesota to the National Health System. So I know that you and our systems are going to look way closer than they do today in just a short period of time. He's a very, very smart man, by the way. You're very, very lucky to get him back. And we hardened him up. You can thank us later. We had the worst winter, one of the worst 3 winters on record, and so we've made him tough. He's a good person to put in charge of the national health system at this stage. Time is going to become an issue here. How much time do I have left? 10 minutes, and we're just getting started. I'm sorry. I talk too much, you guys. I said that there's 5 rules. And I can stand here today and I can guarantee you, I don't know very much, by the way. My knowledge is in a very limited area. That's why I carry Dave with me in my back pocket. But I don't know very much, but I can guarantee you today that if you don't follow these 5 rules, you will never be successful. Not just not successful in the next year or 2, you can't be successful unless you follow these rules. Why don't I stand behind the microphone? You were wondering that, weren't you? These are medicine's rules for patient care providers, and you might not like it, but physicians set the rules. They have for 500 years in medicine, and they will for the next years. We have to quit ignoring that. We have to understand what these rules are, and we have to comply with them. The first one is what you do has to be described simply in terms of what it does for the patient. And I'm going to suggest a few things. First of all, it's time to quit worrying about yourself, okay? It's time to quit worrying about your territory and about your best interest, because if we don't put the patient first, we can't get to square one. A physician can recognize in about 23 seconds who you have in the number 1 position in your mind. And if it isn't the patient, they don't care about you. You're not going to help them, okay? So it's time that you become second or third and most important, because unless the patient's first, you won't get into this club. And trust me, it's a club. It's a club that has these rules. Now, number 1 is everything, and we're going to talk about that the most, but these other rules are important too. What you do has to be based on standards, okay? And I'm talking about standards of care. And these standards mean that you are going to deliver the same service to every patient you see, and this service is going to be delivered the same by every pharmacist who provides the service. The only reason I can sell my service and get paid $180 an encounter for my patient is because I deliver a service that is the same every time, and it produces the same level of quantifiable value every time. I have thousands of pharmacists delivering this service across the country. They all produce the same results because they're delivering the same service. If pharmacist doesn't get this, we can't get to square one. The reason we can't sell this service is everybody does whatever they want to do. It all looks different. Every time a physician turns around, they don't know what to expect. Well, when physicians don't know what to expect, they don't trust you. Trust me, physicians don't trust us, okay? In spite of what we may think about ourselves. We have to integrate with the rest of healthcare. We can no longer sit in our pharmacies and do whatever we feel like doing. We have to integrate with healthcare. You are bringing primary care back. The United States is bringing primary care back through what we call a medical home, which in essence is your GP practices. It took us a while to figure out why our healthcare was so expensive and we were last on the performance evaluation tables. It's because we didn't have primary care working well in the United States. So we have to create an integrated service, and it has to interface with medicine and nursing every single step of the way. So don't isolate yourself. If you're not working with medicine on this, it's never going to happen. You have to generate measurable results that are reproducible. And I'm going to say this about 20 more times in the 7 minutes I have, because unless you're adding unique value, nobody needs you. You're too expensive. You might not think so, but you are too expensive for our breaking healthcare system to be redundant. Don't provide education. Somebody else can do that. Don't, do vaccinations because somebody else does that better. Don't do these things. Just manage a patient's medications and do it well. And you have to be paid the same way other patient care providers. Quit making stuff up. If you want to be a patient care provider, then act like one, sound like one, and think like one. Am I being too obnoxious? No. Oh, I forgot this was being tape recorded. It's okay if I'm not going to have to be accountable, but being accountable is a whole nother thing. I want to talk about this for a minute. Mark, I'm going to talk until you tell me to shut up and sit down, okay? I need to talk to you about this because you can't get to steps 2, 3, 4, and 5 until you do this one right, and you're not doing this one right, okay? In pharmacy, we use a lot of terms. We really like to change those terms because then we don't have to change what we're doing, we just change how we talk about it, okay? So we've come up with a record number of terms for what we do. And we've confused ourselves, to say nothing of confusing patients and physicians. So I want to go through these, and I want you to quit using some terms that don't have any currency in the medical profession, okay? First of all, disease state management was created by the drug industry, okay? It talked about how drugs work, and then managed care adopted that in the United States to be a cost accounting technique, and now some pharmacists think it's a practice, okay? We don't do disease state management because we treat patients, not diseases. So anyone who's out there in terms of interested in treating diseases, go be a pathologist or something else. We treat patients, okay? I'm going to leave medication therapy management. Clinical pharmacy, for the most part, is a consultant service. We never move clinical pharmacy from a consultancy to direct patient care. So everyone who's doing traditional clinical pharmacy, it's not that I'm saying you're not doing useful things. It's not direct patient care, and it's not getting us where we need to go. Clinical pharmacy is a knowledge base. It's not a practice. The other thing I have to encourage you to do is don't use the word model. No patient care provider has a model. They have practices. Models and projects go together. Okay, so strike model from your vocabulary. Sorry, Mark. Only pharmacists use models. We develop practices every single day because practices involve patients, okay? Pharmaceutical care practice, the way that we developed it, it is a professional practice. Okay, it has a philosophy of practice, a patient care process, a practice management system. It has a knowledge base as a foundation. That's what you learn at university. Physicians learn medical care, nurses learn nursing care, dentists learn dental care at universities. What you get paid for in practice is delivering a service. Okay? Professional practice, service. A service is the application of knowledge and a professional practice to benefit a patient directly. All right? Now, our professional practice is pharmaceutical care. The service that we get paid for is comprehensive medication management. Okay? Let me tell you why it's comprehensive medication management. That term came from the physicians, the national medical associations in the United States decided that the service they're going to endorse is the service that has pharmaceutical care as the foundational professional practice. And it's exactly the service that we've defined as comprehensive medication management. I'll say more about that in a minute. But because physicians use this term, It's become our term, and they wanted to differentiate that service from medication therapy management, which is the federal government's way of describing what service they pay for in the drug benefit of Medicare. Does this make sense to you? Okay. So the federal government, because pharmacy confused the hell out of our federal government when they said, what do you want this service to look like? The pharmacy organizations gave them 212 different answers. And they said, are you kidding me? Well, we're going to call that medication therapy management, which I just have to say came from the National Health System. I tell everybody that, by the way. That's why it's called MTM, which don't abbreviate what we do. Have you ever heard a physician say, I'm going to go deliver MC to somebody? It's just disgusting. Don't abbreviate. It means you're too lazy to actually do the service, is what that means, okay? All right, so terminology is everything. Terminology is our identity. Terminology is our currency. The words you use matter. We have to use terms that have currency in medicine. Quit using counseling patients. Just quit it today. Physicians think when someone counsels a patient, they have a clinical degree in psychology, and they're either, right? You need a clinical license to counsel patients, so quit saying we counsel patients. We don't. Sorry, I'm sorry. I didn't intend to get into, okay, keep going, Linda. All right. Okay. So, medication management, comprehensive medication, it's a clinical service. It's integrated with medicine. It's patient-centered. This is more than words. If what you do is not patient-centered, you're not doing pharmaceutical care or comprehensive medication management. Okay, so that's what we do. So pharmaceutical care, I'm going to spend 1 minute on it because I know most of you know what it is, but I'm talking seriously about a standard of care here that you can measure, that is the same every time you deliver a service, that is consistent results, quantifiable results. It has a very specific care process. I don't care if you like it or not. This care process is not Linda Strand's care process. It's medicines and nursings and dentists and veterinarians. You have a care process that starts with ascertaining the patient's needs, in this case, the medication experience. It involves an assessment that lets you identify drug therapy problems. It identifies a care process that lets you create a care plan, and it mandates that you follow up, because if you don't follow up with a patient, you don't care. It's very simple, okay? So that care process is non-negotiable. You don't have to like it. It's not mine. We developed pharmaceutical care to be consistent with medicine and nursing so that it could integrate with those professions on day one. It isn't optional. You will not change these rules. And it has to be a continuum of care. It's not a one and done, I'll do this once and then not care about what happens to the patient. I mean, the fact that we are making decisions that impact a patient's life requires a continuum of care. All of you have seen this probably one too many times, but this is what comprehensive medication management requires. It requires us to evaluate on a patient-specific level what their needs are. It requires that we look at each patient's medication experience and use that experience to engage the patient so that we can achieve a real involvement and real goals that are individualized to this patient. It requires a practitioner who's been taught to think this way. I know all of you have a lot of clinical knowledge, but you have to think in a very prescribed way in order to be efficient and effective at this practice. We need pharmaceutical care, medication management training specifically to learn how to think this way in a very quick and a very effective way. This is going to be what you do. And again, I don't know much for certain, but the reason I know that to be the case is not because we developed the practice, it's because the physicians The national organizations in America have decided that this is what the practice is going to look like. If you go to that website, www.pcpcc.net, this organization is like nothing I've ever seen. The drug companies came together with all the medical associations, with the pharmacy associations, with the patient associations, with AARP, the Retired Persons Association in the US. This organization was responsible for Obamacare. They were responsible for putting primary care back into the national health system in the United States. This organization, I spent 2 years working with the physicians here to make sure that medication management was a required service inside of the medical home, the primary care unit for delivering services. It's probably the most important thing I've ever done because physicians had to agree that this service was important. They had to agree on what this service was, and they had to endorse it as a requirement for certification as a medical home in the United States. That's more than pharmacy has done with pharmaceutical care in 30 years, okay? All right. They have done that, and they have said, these are the steps that you will do in order for physicians to endorse this service. Lucky for us, it's pharmaceutical care practice. And they call the service that results from pharmaceutical care practice comprehensive medication management services. And I don't need to spend time on this because it's exactly pharmaceutical care practice. My point for including these slides is that the physicians have spoken, and this is the way the service that we deliver across the world is going to look like, in my view. Documenting every step is key. The only reason we can sell this service is because we know to the penny what the value of this service is, and that's how we sell the service to health plans, to physicians, to medical directors, to integrated healthcare systems, etc. Okay, just to summarize, getting close. Pharmaceutical care is the professional practice. We have to start using the same terminology. Comprehensive is this clinical service. I don't have time to talk about a generalist practice, but I know you're focused on specialties. Pharmacy is the only profession who thought they could develop a specialist before a generalist. That's not the way medicine works. It also defies the laws of physics, okay? That's not the way it's going to work. You have to develop and provide a generalist service in order to make specialty services meaningful. So all of you, forget being specialists for a little bit. Become a generalist because that's where the value sits in 95% of our patients. The next steps I won't go through because I'm running out of time, but I just want to emphasize this will make you successful, and without it, you won't be. The value propositions anywhere from 4 to 1 up to 12 to 1. We did a controlled study where our return on investment was 12 to 1. We did that in 2003. It was just validated with an actuarial company and one of our clients that the return on investment for this service is 12 to 1. Vaccinations happen to be 4 and 5 to 1. That's a very conservative estimate of the value, and it works so well. So I just want to leave that with you, and I think the most exciting part of this whole endeavor is that it works. It works. It is the most exciting service. We had a physician tell us it's the most exciting service that he's seen come to medicine since antibiotics were developed. These people are serious, and it's time for us to get serious. And so I would love to answer your questions later today, and if there are any resources that I can provide you with for you, I would love to. Dave's going to be here for most of the day, so if you really want to find out how things work in the United States and what your system's going to look like shortly, because he ran one of United Healthcare businesses and worked right under Stevens, so if you want to know what you have to look forward to, you should talk with him before he leaves. Thanks for your attention, and I'm sorry if I went over a bit.